Hello and welcome, friends and colleagues, to this important RSNA webinar on COVID and health disparities. On behalf of the RSNA, I want to thank you all for joining us today. My name is Dr. Carolyn Meltzer. I'll be one of the moderators for this important session. I am an RSNA board member and the board liaison for the COVID-19 task force. As many of you work to address the many complexities of practicing radiology at this difficult time of the COVID pandemic, I wanted to let you know that this webinar is one of the many RSNA resources available to the radiology community. And you can find these resources on the COVID-19 section of the RSNA's website, which is updated weekly and sometimes daily with new information. So a link to this page will be provided in the resources panel on the webinar. So without further ado, I wanted to introduce my wonderful co-moderator, Dr. Yoshimi Anzai. Dr. Anzai is Professor of Radiology and the Associate Chief Quality Officer of the University of Utah Health System. She serves as co-director of the Women in Medicine and Sciences program, and a founding member of the Gender-Based Violence Consortium at the University of Utah. Currently, I'm also very pleased that Dr. Anzai is serving as the chair of the RSNA's Committee on Diversity, Equity, and Inclusion. Welcome, Dr. Anzai. I'll turn things over to you.
Thank you, Dr. Meltzer. Good afternoon or good morning. I'd like to take a moment to thank RSNA board and also RSNA COVID-19 task force for the opportunity to organize this webinar on COVID-19 and health disparities. Before we formally introduce the two fantastic speakers, there are a few slides, things to go over. I'll let you know. One is, so this is you may follow the steps on the screen and in the chat panel to claim the 1 CME credit for this webinar. So please do so. Here are the disclosure and accreditation statement. And here are the RSNA disclaimer statement. And also please use the question panel to submit your question during the webinar. This webinar is being recorded and it will be posted on the RSNA YouTube page within about 1 business day after this event. It will be next Monday, September 21st. So just to give you a little bit of background, what is health disparities? So health disparity is the differences in the incidence, prevalence, mortality, burden of disease, and other adverse health conditions that exist among specific population. This is how NIH defined the health disparities. Now CDC goes a little bit more deeper and granular than that. So health disparity is difference in health outcome that are closely linked with socially and economically disadvantaged populations, which can be defined by race, ethnicity, gender, education, disability, geographic location, or sexual orientations. Now, health disparity has been a chronic, long-standing, serious public health problem for decades in these countries. And it can be seen in many conditions, including AIDS-related mortality, maternal mortality, cardiovascular disease, diabetes care, and also prostate, colon, and breast cancer mortalities. There's been higher amputation rate for the peripheral vascular occlusive disease and lower kidney transplant rate and so on. So it is very pervasive across all of the medical conditions. However, the COVID-19 shed a really strong, intense spotlight on a health disparity as we observed undeniable disproportional rate of a high mortality among the underrepresented minority. And earlier in the spring, we noticed that a higher mortality among African-American patients. For example, in Milwaukee, Blacks account for 26% of population, but account for 73% of COVID-related mortalities. In Chicago, Black account for 32% of population, but 67% of mortality, and so on. So the health disparity issue has been very pervasive, but really COVID-19 brought a whole discussion to the very surface. It's in front of our face. So in this webinar, we will discuss what we learned in the past several months, and also what we radiologists can do to mitigate the impact of health disparities. So we have two fantastic, outstanding panelists today with us, Dr. Paul Rochon and also Dr. Dania Day. So let's go there. So let me introduce the two speakers. First, Dr. Paul Rochon is a vascular and interventional radiologist at the University of Colorado School of Medicine. He is an associate professor of radiology, as well as a program director for the Integrated Interventional Radiology Residency, and a director of Diversity, Equity, and Inclusion of Department of Radiology. Now, Dr. Dania Day is also an interventional radiologist at the Massachusetts General Hospital and an instructor of radiology at Harvard Medical School. She is co-chair of the MGH Radiology Diversity, Equity, and Inclusion Committee, and also served on the MGH Equity and Community Health COVID-19 Task Force. Welcome, Dr. Rochon and Dr. Day. And Dr. Rochon will begin with uncovering health disparity during COVID-19.
Thank you very much, Dr. Anzai and Dr. Meltzer. It's a pleasure to be on this RSNA webinar and share with you my thoughts on COVID-19 health disparities. But before I begin, I'd like to ask the audience two questions. If we can bring the first polling question up. And that question is, which of the following best describes your practice type? Choices are academic center, hybrid academic and private practice, large private practice, small private practice, or others. You know, there are a lot of different varieties of practices that we have these days, especially across the continents. And we have a lot of members who are joining us from Mexico and other areas today. Okay, wonderful. All right, we'll go to the second polling question, please. Which of the following factors do you think contribute to higher mortality due to COVID-19 among underrepresented minorities? And in this question, please choose all that apply. Just about finished with this polling question. And the first polling question, majority of practice types were academic centers, then others, and then a hybrid academic and private practice. And in the second polling question, the factors that contribute to higher mortality, pretty much across the board, but leading the pack is access to healthcare and medical comorbidity. It's good to see the controversial genetics is actually one of the lower chosen choices. But we'll go ahead and discuss this hopefully throughout the webinar. And if you have any questions, please use the chat box in the questions. Okay, we'll move on. We'll close the polling questions and move on to the talk. So uncovering health disparities during COVID. The objectives of my talk are to discuss the impact of COVID-19 on health disparities in vulnerable populations, to discuss social determinants that contribute to these disparities, and also to discuss ways that we, as radiologists, can further address these disparities. Back in March and February earlier this year, we were stricken by COVID-19. And this paper showed the hospitalization rates and characterizations of patients hospitalized with laboratory confirmed COVID during March, which was a peak of our season. And about 33% of these hospitalized patients were Black. And that was only representing 18% in the community. As Dr. Anzai noted, that the population and the patients of color who are positive with COVID do not match. In New York, Black and African American and Latino Hispanic persons have substantially higher death rates, 92 and 74%, compared to white and Asian patients in New York. So that in itself leading to the disparity. Also, a paper came out in Morbidity and Mortality Weekly Report, which showed a larger catch and time period of the incidence of COVID-19, but looking at some of the hotspots in the United States and grouped the counties associated. And going back, the disparities were defined as a percentage of difference of greater than 5% between the proportion of cases or the ratio of greater than 1.5 for the underrepresented racial and ethnic groups in each county. This table shows the states and the number of counties, but more importantly, how many Hispanic groups in these counties were affected, 59. And then as we go down the table, Blacks 22% and other minorities affected. So 59 Hispanic groups in these counties were actually affected compared to the normal population. And these two tables also show the approximate of persons living in these hotspots and with the amount who are affected. Again, 59% Hispanic and 22% Black. So this is telling us, what did this tell us? Reduction of disparities in COVID-19 incidents can be done with efforts from culturally responsive and targeted interventions. Universal reporting of race and ethnicity data can help inform efforts in short term to better understand patterns of incidence and mortality. And this addresses the need for investment in social determinants and structural racism that affect health inequities. So COVID-19 and health disparities, the reason why we're having this webinar today, is this random? Well, immigrants, I don't think so. Immigrants and underrepresented groups work for decreased pay and take on essential jobs instead of facing the crisis at home. This takes us back to March and April, when many of our states and many of our patients and us were quarantined during this pandemic. About 25% of Blacks and Hispanics work in the service industry jobs, compared to 16% of non-Hispanic whites. So they don't have the luxury of working from home. They have to take care of their families. They don't have any other ways of having any paid sick leave. Their benefits may be cut if they do not show up for work. So this leads to, they have to go to work, and our healthcare system is definitely unbalanced whenever these pandemics actually hit. Is this a coincidence? Dr. Anzai talked about the other pandemics and disparities that have affected us. The HIV pandemic really mirrors what we're going through today. It initially emerged amongst white male homosexuals, but the Black population, Hispanic population, were not immune to this. Now Black males are disproportionately affected by HIV. Well, what's the difference between the HIV pandemic and our COVID pandemic as we speak? Well, we have more data for HIV. We need to acquire more demographics and data for COVID-19 in order to fully address these health disparities. Now moving on to our social determinants. Social isolation was one thing that we are still doing. Social distancing, there are many terms of how we're using this. Some may argue to say not social, but why don't we say physical distancing? When we talk about lack of social connections and some of these marginalized groups. This is how we have a key to happiness. We are human beings. We thrive on connections, and that's part of our wellness. Also, with our social isolation, this leads to no access to virtual technology, where we are privileged today to have this RSNA webinar through virtual technology. But some of our patients and those from marginalized groups do not have that benefit of communicating via these platforms. Also with transportation and limiting those patients and marginalized groups cannot get to work, cannot get to their appointments. Or in the virtual technology phase and virtual appointments, maybe they may not be able to follow up with their appointments. Now moving on to healthcare, the center of our lives. These patients have decreased access to healthcare and health insurance. These underlying systemic conditions such as diabetes and hypertension, which we are associating with COVID-19, they have an impact. And then with all of the things that are happening in the majority of underrepresented minorities, Blacks and Hispanics being stricken by this COVID-19, there's now a distrust maybe in healthcare on, well, when I go to the, when I don't want to go to the hospital, I don't want to go to my clinic appointment because I'm at higher risk. Now moving on to a social determinant of nutrition. This dovetails back to diabetes and hypertension. The lack of resources and availability of healthy food, of food that can actually, that's not expensive, affordable food. Well, that leads to obesity when there's a lack of resources and availability. And then climate change. A lot of marginalized groups are in higher populations and areas, these hotspots, lead to heat illness, water and foodborne illnesses, etc. This slide was shared by one of my good friends and colleagues, Dr. Shanta Zimmer, and she looked at the preliminary characteristics of patients that we saw in our hospital. This was around March and April. About 145 patients entered into the database. 64 were intubated out of the 145. The median age was 53. BMI was high at 31.7. Say it again, hypertension and diabetes were the most common comorbidities, and cough was the most common presenting symptom. Now let's break it down to racial and ethnicity. Among the cohort of 145 patients, 70 to 85 hospitalized patients with COVID-19 identified as non-white. Now that is just the opposite of what we normally saw in our ICU, where the majority were white. This really uncovered the disparity in COVID. Amongst Colorado, our population in 2018 compared to today in COVID-19 cases, the disproportionate of patients who are Hispanic, patients who are Black, as Dr. Anzai talked about, does not add up. More patients in the Black and Hispanic population are affected by COVID compared to how many we have in the population. The proportion is just striking. So it is really good to see that our colleagues, you, are looking at these disparities. My co-panelist, Dr. Adanya Day, her institution, thoracic section, looked at the racial and ethnic disparities in disease severity on admission chest radiographs among patients admitted with confirmed COVID-19. And although this was a retrospective study, this showed us what was going on. And the conclusion was that non-white patients hospitalized with COVID-19 infection were more likely to present with higher severity of disease on admission chest radiographs than white non-Hispanic patients. And increased severity was associated with worse outcomes for all patients. These are the things that we need, the data that we need from all of us, all of radiologists. And I'm really happy to see this in radiology. How does this affect radiologists altogether? Well, some of us may not have direct contact with patients. I'm an interventional radiologist. I still participate in diagnostic radiology and then have a lot of colleagues. But the question is, what is our role? What are their roles? Some of us may not directly treat patients, but that does not mean that this COVID-19 in healthcare, in our specialty, we can't play a role. But it still affects us because our images are our patients. And what are the chances that this patient is non-white? Those are the things we need to be thinking about whenever we're addressing these health disparities. Okay. Oh, 75 to 80%. Excuse me, I had a little technical difficulty there. Now moving on to a story that I wanted to share with everyone. Whenever we were hit with COVID, we looked at different recommendations and protocols that we would apply in a lot of our institutions and practices. One, for instance, were CT scans. CT scans, per the recommendations of ACR, which should not be used to screen any patient or first-line diagnosis for COVID-19. Totally reasonable. These guidelines and recommendations were placed to protect us, protect those first-line workers. And I applaud these recommendations, and that they should be used sparingly for those hospitalized patients and reserved for those symptomatic and for specific indications for CT. But moving on, there's a dilemma here. What if we have an inpatient with COVID-19 with a concern for a pulmonary embolus? Normally, we get a CT-PE scan, right? This patient has shortness of breath, other things associated with this. COVID-19 is speculated to be associated with hypocoagulable states. Chances are, 75 to 80% of the time, that this patient may be non-white. It may be misconstrued by our colleagues who are referring these patients to us that we're not scanning patients with COVID-19, even though our guidelines are not specifically saying that. Or it may be looked at as we put up a fight with referring providers ordering these scans for these COVID-19 patients, who by percentage are marginalized patients who suffer from health disparities. What is needed here? We need to communicate our guidelines. We need to work hand in hand with our referring physicians and focus on these health disparities and again, try to protect our first-line workers, but also note that there's patients who may have an indication that may change the way that we treat them. This is a systemic impact. This is how we can actually play a role in health disparities. Even though a lot of us may not see patients in clinic, we read hundreds and hundreds of scans of these patients who are coming in. And how can we address the patients who cannot come in and get any scans? That's another way that we can actually play a role. We can play a role in our community as well. In Colorado, a health equity response team was developed to look at different ways of why patients and we're not getting the same treatment and some of the marginalized groups. There are other states that are also doing this. And what can we do as healthcare systems and providers? First of all, addressing implicit bias, something that we all have, something that we all need to be aware of. This can be addressed in our institutions and our practices, and also creating safe spaces for us to understand differences among each other. We can look into standardizing protocols and quality improvement initiatives to address these health disparities, such as the protocol and recommendations for getting CT scans during pandemics. Now looking back at, well, how does this address health disparities in patients who are marginalized and groups who are more vulnerable? Providing appropriate medical interpretation services. Dr. Day is going to talk more about this. So now I'd like to leave you with questions to reflect upon, not specifically to answer right now, but how have you noticed health disparities in your practice? How can we further address these in our community? And what delayed impact will have will this have on our marginalized and vulnerable communities? Going back to the polling question, the majority of the responses were access to healthcare. Those are things that we can have a really systemic impact on focusing on this as we move forward. And what I'd like to leave with all of you today is that disasters do not create disparities, they uncover them. Thank you very much for your attention.
Thank you. Thank you, PJ, Dr. Rochon. A really wonderful, comprehensive overview, and also pointed out the many critical points of the health disparity in COVID-19. Thank you so much. Now, next, I like to call Dr. Dania Day. She'll be presenting a Tackling Healthcare Disparity During COVID-19, the Radiologist Role. Dr. Day.
Thank you, Dr. Anzai. Before I begin, I have a few more questions for the audience. Please respond to the poll questions appearing on your screen. For our first question, does your practice have radiology information toward patients translated to a non-English language? And the answers are yes, no, or I do not know. So the answers are coming in here. It seems that most people are answering yes, with about 30% answering I do not know. We'll just give a few more seconds for this question. All right, so it seems about 60% or so are saying yes to this question, with about 17% saying no. So we'll move on to the next question. Does your department or practice have a committee for diversity and inclusion? And the answers here are yes, no, thinking about creating one, or I do not know. So we'll give everyone a few seconds. So it seems about the majority of people are saying yes, between 55 and 60%, with about 25% saying no, and 15% not sure if they have a committee for diversity and inclusion. It seems that now we're at about 50% saying yes. So certainly I know this is an area that's of interest to a lot of people. And we'll talk more about this when we talk about the radiologist's role in addressing healthcare disparities. So we'll move on to the third question. Your race and ethnicity, just for data collection purposes here. And you can check all that applies. All right, it seems that we have on the webinar today about 42% Asian, 33% white, 12% Hispanic, and 9% Black. So thank you all for joining us again today. So with this, we'll close the poll questions, and I'll start with my presentation here. So again, thank you for having me today. I'll be talking about tackling healthcare disparities during COVID-19, and what is the radiologist's role during the pandemic in terms of addressing disparities. So I'll start with a brief outline. When it comes to addressing healthcare disparities, there are a number of areas that we have to think about, specifically addressing disparities relating to patients with limited health literacy, patients with limited English proficiency, and patients with limited access to the healthcare system. We also should think about addressing the patient-provider trust, as well as the staff psychological safety. And finally, I'll present some of the work we've been working on here at MGH to disseminate some of the solutions that we've used in our system to anyone who can use those resources. So to start off about what is the approach to address healthcare disparities? And one of the most important things to think about is that this has to be a multi-pronged approach. There is no one person that can solve this issue. As Dr. Rochon mentioned, this is a long-standing and very, very complex issue that needs to be addressed. And for us here in our department, we started with a number of departmental specific resources in radiology that I'll talk about in more detail, but we also worked very closely with the hospital and hospital system in general to plug in radiologists in those roles. And we also were involved in a number of community outreach efforts that proved to be very important that we'll also discuss in today's talk. So for the radiology specific COVID response, we focused on 4 different areas. Specifically for the patient population we served at MGH, we focused on addressing the language barrier for our patients. We focused on addressing health literacy and also the patient-provider trust. And I'll talk a little bit about psychological safety in the setting of what happened in terms of calling the virus, the Chinese virus, et cetera, some of the implications that happened as a result. So I'll start the first section by talking about addressing health literacy, which we all know is an issue that unfortunately affects our underrepresented minority populations that we serve. So when the COVID-19 pandemic started, the hospital overall recognized that this is going to be an issue, and they put together an MGH Equity and Community Health COVID response team. And this was really a system-wide effort to ensure that patients are treated equitably and have access to the necessary information during COVID-19. As we all remember, at the beginning of the pandemic, there was a lot of misinformation being spread around, and that certainly was an issue that we were trying to mitigate. So to address this issue, they created a COVID-19 webpage, which I'm showing here a screenshot of. And with time, this webpage progressed to have translations of everything on the page, information for patients, visitors, employees in a number of different languages. And they also created a hotline that was available to anyone, regardless of immigration status or insurance, or whether or not they were seen at MGH, also to spread awareness and have people have access to reliable information as the pandemic was progressing. And that proved to be a very effective approach, and really helped a lot of the populations that we served, especially our populations that spoke other languages. So I'm sure the question here is, so this is a great initiative, how was radiology involved? So radiologists do have a very big role to play with this, and here I'm showing one of our radiologist, Dr. Gil Gonzalez, who's the chief of MGH Neuroradiology, who volunteered as part of this process and recorded a public service announcement in Spanish for some of the patient populations that we serve, talking about COVID-19 and social distancing, among other things, as part of the hospital COVID response team addressing equity and community health. So in the radiology department, we also contributed to this effort as well. And we used our social media for outreach. And here we're showing that our MGH Rad Diversity Twitter account was posting a number of tweets in Spanish targeted to our patient population. Also there, Dr. Efren Flores, who's the director of community health, was also using Twitter as a platform to disseminate information and to outreach to our patient populations that we serve. In addition to the outreach to the community, also, we recognized very early on that it's extremely important to disseminate information internally as well, and make sure that everyone in our department was also aware of some of the resources that we had available. So near the beginning of the pandemic, we created a departmental COVID-19 response website. And you can see here in the second panel that I have is that we had a specific section that was on diversity, equity, and inclusion, where we summarize a lot of the initiatives and the resources that were available to everyone in the department as we were trying to ensure equitable care to all the patient populations that we served. So moving on to addressing the issues facing our patients with limited English proficiency during COVID-19, and how can radiologists help with this? So near the beginning of the pandemic, and also as Dr. Rochon mentioned, we recognized that unfortunately COVID-19 was affecting our underrepresented minorities disproportionately. And for us here at MGH, one of the largest populations that was being affected that we were seeing in the hospital and our clinics was our Spanish-speaking Latinx population. So one of the issues that came up early on is how can we facilitate the interactions with patients with limited English proficiency, especially as our interpreter services were getting inundated and overwhelmed with all the requests that they were getting. So in terms of our needs at that point, we needed to come up with ways to facilitate the patient radiology tech interaction, ensure that the patient had the correct instructions in their native languages as they were getting radiology exams done, and save time and interpreter resources, which certainly were needed in more critical situations inside the hospital. So, for example, one of the things that we were focusing on is how can we translate sample imaging instructions for our patients who are coming in for chest x-rays, obviously, which was one of the most common exams that we performed during the COVID-19 pandemic. So as the patient comes in, we needed to find ways to have the text ask the patients, what is your full name in different languages, ask them about their date of birth, any chance they can be pregnant, tell them to take a deep breath and hold it, etc. So we worked early on with our strategic communication team here at in the radiology department at MGH. And our first solution that was rolled out is coming up with posters that we posted in our respiratory infection clinics that were brought up during COVID to treat all the patients that were coming in with COVID symptoms. So we put posters with the chest x-ray preparation instructions in English, as well as an equivalent poster in Spanish in our respiratory infection clinics to be available to all the patients that we were seeing. And some of the instructions on those posters had to do with what to wear to your exam. Let us know if there's any chance you can be pregnant. During the exam, we're going to ask you to take a deep breath and hold it, among other things. And that was the beginning of our response to start addressing some of these issues. So as the pandemic was progressing, some of our committee members for the Diversity, Equity, and Inclusion Committee at MGH in the Department of Radiology, specifically Jennifer McGowan, one of our techs, and Joy Williams, one of our NPs, brought to our attention that we need to have a better approach to be able to translate some of the instructions inside the exam room to our patient. And as a result, we collaborated with the Mesh Incubator here at MGH to come up with an app that's available now online, actually, to anyone at radtranslate.com. And through that app, we have a number of different languages available. And you can select, for example, for a chest x-ray exam, it will, you can see here on the second and third screen, it can open up all the instructions that you can think of that will be required for a tech to say during the x-ray exam to a patient. And you can just click on the play, and there's an AI-enabled voice that will actually read those instructions in the language that you select. So for example, here, what is your full name? You can click on the button right above it, and it will say that instruction in Spanish for the patient. And Rad Translate has been a very big success, and we're now developing a number of other exams that are going to be available through that platform for anyone to use. So as an adjunct to that, we also created a number of video scripts in Spanish with instructions about chest x-ray. Here we're showing Dr. Efren Flores, again, the director of our community health, who created a number of PSAs about chest x-rays in Spanish that were also available to our patient population as they were getting their x-rays done. So at the broader hospital level, The radiologists were also involved in an initiative called the Spanish Language Care Group. And that initiative really came because we recognized, or the hospital recognized, that there needs to be a way to improve symptoms assessment and explain care plans and facilitate informed consent for our Spanish-speaking populations. So they put out a call for volunteers, specifically clinicians, to participate in that. And the idea was to have clinical volunteers sign up to assist care teams in regular floors and in the ICU 24/7. People would sign up for either day shifts or night shifts, and they would be available by pager if any of the teams needed help with some of those conversations with the Spanish-speaking patients. So for us in radiology, again, radiology had a good role in this, or a significant role, where we had 7 of our radiologists volunteer to participate in the Spanish language care group and help with that effort. And the last component in terms of helping our patients with limited English proficiency, we contributed to the hospital-wide multilingual staff registry, where we sent out a survey to identify any of our radiology employees who spoke other languages and their level of comfort with those languages. So from radiology, we had 60 registrants who expressed that they spoke different languages, their comfort level, and some of them even went through the formal certification process to be able to function as interpreters if needed. And we had specifically many volunteers in Spanish, Chinese, Arabic, Korean, and French, among others. And this is a great resource that is still available for us today as we develop more resources to our non-English speaking patients. So moving on about our role in the community and assessing disparities in access and resources. I'll just talk about this very briefly. As I mentioned, at the beginning of the pandemic, we recognized that one of the cities adjacent to Boston, Chelsea, had the highest rate of COVID-19 in the state of Massachusetts, and social distancing there was especially an issue. So we worked with the hospital on some of these interventions. Those were all hospital-led interventions to address some of these issues, and the hospital put forth resources to secure hotel rooms for residents who were sick and could not socially isolate to reduce the infection rate. We also did participate in community-based videos, as I showed the PSAs that went out in Spanish and English about COVID-19. We also had volunteers assist in assembling and distributing quarantine kits, including masks, to those communities. And we collaborated with some of the community organizations to ensure access to food in those populations. So again, radiologists can contribute in a number of not only departmental but hospital-wide initiatives. And finally, very briefly, in the interest of time here, I will just say that at the beginning of COVID, obviously, as the virus was being called the Chinese virus, there were some incidents of aggression against our Chinese or our Asian American colleagues. And we had a webinar that was put together about confronting xenophobia and how to address that. So just here in the last few minutes, I wanted to share with everyone some of the resources that we put together at MGH that are now available online. So many of the resources that I discussed today are now available on the mghraddiversity.org website that can be accessed, and it will have a toolkit with all the COVID-19 response equity resources that were discussed today. So with this, I hope I was able to convey that radiologists play a key role in addressing healthcare disparities during COVID-19 by addressing all the issues facing, or many of the issues facing, our patients with limited English proficiency, limited health literacy, and limited access to resources and healthcare. And I hope you'll find the toolkit that we put together helpful as you design your own COVID-19 equity response. And with this, I would like to thank my co-leaders for the MGH Radiology Equity, Diversity, and Inclusion Committee, Dr. Anand Ryan, my co-chair, Dr. Efren Flores, the Director of Community Health, and Carmen Alvarez, our Program Director, and thank you for your attention.
Thank you, Dr. Day. That was really fantastic. There's so much you have done in the MGH to reach out to the community. So huge kudos to all of you, your team. I'd like to take a moment to take a Q&A. There are quite a few very good questions from audience, if that's okay. I'd like to take a first question from Melissa Seeley Morgan. I wonder what community outreach program your hospital provide to reach underserved populations. Transportation clinic or using community health worker for high ED user. This is for Dr. Day. Would you be able to address that question?
Yes, absolutely. So there are a number of resources that can be available to assist our patient populations. And I know you mentioned specifically transportation. We do have a program at MGH where we do have rides that are being made available to transport some of our patients to the imaging centers to ensure that they make their appointments. And this is one of our very successful programs that is run by Dr. Efren Flores. So I'm happy to share more information about that program if that's of interest.
Oh, wonderful. Great. Dr. Rochon, do you have anything to add to the question by Dr. Melissa Seeley Morgan about community outreach program at University of Colorado?
Yes, thank you, Dr. Anzai. I mean, in addition to the great things that Massachusetts General is doing with Dr. Day, some of the things that we're doing as an institution, our academic institution, we have groups, departmental leaders of diversity of all the specialties that are that meet to actually address these things that we need to do in the community. We also have an organization called UColores. It's University of Colorado Organization for Racial and Ethnic Support. And we have monthly webinars and seminars, both focused for hospital and departments, as well as community outreach of things that we do. And we invite our community to also participate. One thing that we have starting now, and it has been initiated through one of our Department of Medicine and Radiology colleagues, is our Urban Underserved Track, which we are going to go into the community to not speak about things about medicine and healthcare, but on the contrary, sit down and listen to our community of what things that we need to be addressing more so. What things, and the question that we have, is it access to healthcare? Is it other comorbidities? What problems and issues are our marginalized groups having? So not us going in there to lecture, but we're going to be the audience and listen and see what things that we can put into action.
That's great. Wonderful. Yeah, there's so many things that we could have done and that we should be doing. I think it's a great idea to just have a discussion around this. The next question by Carolyn Berg about, I've read about COVID mortality rate among the Blacks are also high in England, where they already have a socialized medicine. So is that true? And if so, how does this impact the assumption that the lack of access of the care is a high mortality, is at the core high mortality and morbidity rate for this underserved community? So Dr. Rochon, would you be able to address that? That's a very interesting question.
Dr. Anzai, that is a great question, especially with how health disparities affects all of us across this globe. And yes, I agree with Karen Burke's question about, it's an assumption. And that's why there's so many things that we should be looking at of why we're having these health disparities. Now, I do not know the specifics on how many Blacks are affected in England compared to the population with socialized medicine. But I would also question, well, what things are they doing better? What things are they still not doing better? Are these Black patients or Black community individuals, what living environments do they have? What access do they have and don't they have? There are a lot of things that we need to look into. I mean, now that brings into play some other comorbidities. Do they have other comorbidities such as hypertension and diabetes? What is socialized medicine? What are the limitations of that too? I mean, before we jump into this in terms of we want healthcare, equity of healthcare for all of our individuals here in the United States, but what things can we learn from other countries as well, of what things that we need to look at for, what pitfalls we have? So that's a great question. I don't have the specific answer, but it just plays into, there are multiple factors that we need to be looking at, and we need the data.
I agree. So one thing is that you mentioned, both of you mentioned about distrust to the health system. So there's some, even though you may have access to healthcare, you may be able to go to hospital for the care, but there are some fundamental psychological distrust to the health system, or they are not able to communicate well with the healthcare provider. And then that's interesting pieces that we don't often think about. So would you elaborate, both of you, either Dr. Rochon or Dr. Day, that how do you address that distrust among underrepresented minority patients to healthcare provider?
Dr. Day, you can go first.
Sure. So I think this is a very important question, and there is a lot of data showing that there is definitely a certain degree of distrust by underrepresented minorities when they come to our healthcare institutions. And some of the solutions that have been proposed in the literature and the data does support it, is that when you have providers of the same ethnicity or providers who speak the same language, there is definitely a better way to establish that doctor-patient relationship to ensure that you have a more therapeutic relationship. So this is one of the things that was the focus of some of our efforts, is ensuring that we have a diversity of the people who are contributing to our efforts, especially when they were doing the public service announcements or things along those lines, to make sure that we can build that trust and maintain it, and ensure that everyone felt that they belonged as they came to our healthcare system.
I echo that, Dr. Day. Our patients, I mean, specifically ask for people who relate to them, and they may have similar backgrounds. This goes back to our implicit bias and things like that, and goes into recruitment, that we as institutions, both radiology and healthcare, all medical specialties, increasing the recruitment of underrepresented minorities, people of color, women. This is very, very important, so that we can actually mimic the patients who we treat, the populations that we treat. I've had patients come up to me and other individuals and say that, wow, it's good to see you there as a doctor. And it's appalling. It's great to feel that way, but we need more people of color, underrepresented minorities. And that goes back to recruitment. That goes to faculty recruitment. That goes back to medical school. That goes back to, again, community outreach that all of us can be doing to open up the doors for people who can actually change this outlook for us.
Absolutely. Thank you. Thank you, Peter. That's really wonderful. Both Dr. Day and Dr. Rochon. The last question I wanted to ask is how can radiology play a role in decreased diversity at that post-COVID or COVID recovery period? Now, I don't think it's completely ended yet, but at the same time, we are kind of different phases of a COVID-19. In the recovery phases, is there anything that we radiologists can do? Dr. Day or Dr. Rochon, either way.
Sure, I can start answering this one. So I think, as we saw during the pandemic, that a lot of people certainly lost their jobs and lost their insurances, etc. And unfortunately, we knew from the data that affected the underrepresented minorities in a disproportionate way. So one of the things that we need to be very careful about in the recovery stage is to look at the data of who is actually coming back to our hospitals. And is there a disparity in access in terms of who is returning for care? One of the things that we are working on through the MGH Radiology Diversity, Equity, and Inclusion Committee is we're pulling that data right now and trying to assess if there are any disparities in access of who is returning, so we can design interventions that might be needed in case we see any disparities along those lines. So definitely radiology has a very big role, especially who is returning for our imaging in our department.
Wonderful. Dr. Rochon, do you have anything to add?
Yes, Dr. Anzai, and it's the access. I mean, that goes back to that access of care. What can we do? We have mostly radiologists who will be listening to this, but how can we get our patients back to get their scans that are ordered? Can we actually work with other institutions to make sure that these scans are actually delivered appropriately to our patients? For our interventional radiologists and breast radiologists who are seeing patients, how can we optimize telehealth whenever this may actually maybe uncover again? We are asked to see more of our patients in the hospital right now, but some of them cannot get here. Some of them may not have that technology. So how can we distribute that and make sure it's equitable for all to do that?
Excellent. Yeah, I've heard it from a colleague of mine in there's a mammal ban that you can't expect the underrepresented minority women to come to breast screening mammogram, but if you reach out to them with a mammal ban, then they'll be able to get a breast cancer screening. That's a great example. The other things that Dr. Day mentioned about that data, we found that through this COVID-19 that we just don't have a good racial ethnic data to do thorough analysis. So I think we now know that this is a very important part of the social determinants of health, and any upcoming disease or pandemics, we probably have to start thinking about collecting racial ethnic data for each institution. So thank you so much. Now I'm gonna just show last slide of a COVID-19 and a health disparity call for action. So we came up with the 5 things that maybe every one of you at your own department or practice can do. Number 1, create departmental or practice committee on diversity and inclusion. This is not so hard. We can find some like-minded people to address the diversity and inclusion issue. Number 2, include a CDI representative, Committee on Diversity and Inclusion representative on the main departmental operational committee. Not just having them, but really be a part of the discussion for decision-making. Number 3, address health disparity by promoting health literacy. Dr. Day has shown all this health literacy for different languages. People may not understand the healthcare because language barrier. Number 4, engage and partner with community organization where disparities are pronounced. So we can do community outreach program if we connected with the community partner. MGH has done an amazing job, and you can learn from their experience as well. And lastly, we talk about access a lot in this webinar, but expand access to care by advocacy work locally and nationally. I know Medicaid expansion will be really wonderful. ACA, that's another one piece of puzzle, but we can all be advocacy work. We can engage in advocacy work so that we can provide a healthcare access to those people who may not be able to right now. I like the Melissa. Thank you so much, Melissa. Another question. All of the information is important discussions, and other than posting on our MGH website, we like to share that with you. But I think MGH toolkit actually is available to public, correct, Dr. Day?
Yes, that's correct.
Great. So I think you should be able to do this. So with that, I will take to Dr. Meltzer for final closing remarks.
So thank you so much to our Dr. Day, Dr. Rochon, Dr. Anzai. I worry that these health disparities that we've talked about will continue to be an issue in COVID as we see patients coming back with chronic effects of COVID, and whether we can get them into our health system, get the right tests, and they feel comfortable. So lots more to discuss, but unfortunately, we'll conclude for now. I want to thank everybody who's joined us today, thank our panel for their expertise, and just to let our those who've joined us, you can look in the resources panel for details on how to earn CME for this webinar. I also encourage you to continue this conversation on RSNA's new community site, where colleagues and leadership can comment, answer questions, continue the discussion. So thank you so much to all, and have a wonderful weekend.
Great. Thank you so much for tuning in. Thank you, Dr. Rochon, Dr. Day. That was a fantastic talk. Dr. Meltzer, thank you so much for your support.